Welcome to the Colorado Baby Friendly Hospital Collaborative's first webinar. So given that it's our first webinar, I hope you'll understand if we have some difficulties. I'm Jennifer Delaporte, the breastfeeding specialist for the Colorado Department of Public Health and Environment's Prevention Services Division. And today's webinar is about step 3 of the Baby Friendly Hospital's 10 steps to successful breastfeeding. We have a knowledgeable and experienced group of speakers today, and the content for this webinar evolved from the feedback that you hospital staff provided on the evaluations from the September kickoff workshop that we had, as well as from ideas of the advisory committee that we have for this collaborative. So thank you for providing input as to how we can assist you through the Baby Friendly Hospital pathways. So our objectives for the webinar today is that you as Colorado Baby Friendly Hospital Collaborative participants, you'll learn the process to apply for the one-time supportive funding, and hopefully you'll learn at least one answer to your questions on how to achieve the guidelines for step 3, and at least one useful thing, be it an idea, a process, a practice, to consider implementing in your hospital. So I wanted to just take a few minutes to really briefly give you an update on the collaborative. We have a charter that is almost done with being drafted that I will, the charter itself will describe the responsibilities of the State Health Department with you hospital members and then your member responsibilities. These responsibilities are the ones we talked about at the workshop, so they shouldn't be anything new to you. What I'm going to do in a couple days is send out this charter to the people I have listed as contacts for your hospital. And you can see the hospital names and quickly look up to see your hospital, and if the contact person that I have there is still with you, you don't need to give me feedback, but if there's been a staffing change, please let me know. Additionally, when I send this charter to the contact person, I will CC the other names that I have for the hospital. So be looking for your charter, and your facility's acceptance of this charter, or the terms of the charter, are required for applying for the funds. So the application for the funding is also ready to be sent to your hospital's contact person, and I'm really sorry for the delay with this activity. So just recall that this is the one-time fund, so while you're on this pathway, we're providing $5,000 to $6,000, depending upon the number of deliveries or live births your hospital has, to support one or more activities that we've described to you in the past. But basically, you could use it for baby-friendly hospital fees and or staff training and or establishing these community connections to meet the guidelines of step 3 and 10. So be watching for those in the next, hopefully within the next 2 weeks you'll see those, and I expect that we'll be able to get a quick turnaround to those hospitals that receive funding this year. And again, that funding is good through June 30th. Okay, so now in order to do a smooth transition between presentations, I'm going to introduce all the presenters at once because not everybody's in the room with me, and then we'll just let the presenters talk. So today we have Trish McEnroe speaking with us from New York. She will provide an overview of step 3, and Trish, along with a panel of colleagues, will address your questions, both the ones that you submitted over the last month or so, and then those that are raised after the presentation. So some of you will remember Ms. McEnroe as she presented at the Colorado Hospital Breastfeeding Summit last year. She's the Executive Director of Baby Friendly USA and a former chair and treasurer of the New York State Breastfeeding Coalition and the former chair of the WIC Association of New York State, and she's a delightful person to work with. And at Baby Friendly USA, she's organized the Baby Friendly designation process and created the tools to assist your facilities with pursuing designation. And most recently, she was She reorganized the redesignation process as well as implemented an annual quality improvement program for the designated facilities. So we're going to actually eventually turn this over to Trish, but I also want to introduce you to the panel who will also interject their comments as we go through the questions and answers. And joining me in the room is Kathy Janoka as a member of a hospital in the dissemination phase. Kathy is a nurse and a IBCLC and has worked in the lactation department at Memorial Health Systems Hospital for over 15 years. And this year, Memorial Hospital recently became part of the University of Colorado Health System, which is, Memorial is also a part of the National Best Baby-Friendly Hospital Collaborative, which is a Best Fed Beginnings national project. She is and has been a Leche League leader for 30 years, and so she has experience in trying to develop systems that strengthen continuity of lactation support after mothers leave the hospital. We also have Tamara Martin, who is a nurse manager for the NICU and pediatrics department, and she's joining us from Skyridge Medical Center, which has just moved into the dissemination phase. However, Tamara began her baby-friendly hospital experience in California in 2009 as part of her hospital's baby-friendly task force when she was a staff nurse in the NICU. The hospital, so this one in California, had breastfeeding rates that were some of the lowest in the county at only 16% exclusively breastfeeding. So trained under Karen Peters and using the Birth and Beyond California training program, she worked with other members at their hospital to train over 150 nurses and MCH staff. And then Tamara moved here just last year, and she reports that this California hospital is waiting for certification and continues to work on many of the same challenges we all have. So, however, they're reporting exclusive breastfeeding rates now of about 60 to 70%, which is about a 50 percentage point increase. So Tamara brings with her experiences from having gone through the process with another hospital. She brings that to all of us and to Skyridge. So thank you very much, all of you, for volunteering to provide information on this webinar.
Thank you, Lori, for your delightful introduction, and it's always a pleasure to work with you and Jennifer. I'm also delighted to be here with Eileen, Karen, and Kathy. You've all done some amazing work, and Colorado's efforts have been stellar to date, and it's a real treat to be here with you all. So I'd like to commend you all for tackling the challenges of addressing step 3. I think step 3 is a really fun step, and one of the things I like about it the most is I think there's a lot of opportunity for collaboration along with step 3. And as a collaborator, I find that to be very exciting and very energizing. And so I hope, while I believe step 3 to be among the most challenging of all of the 10 steps to successful breastfeeding, I hope that you all find that the collaboration opportunities are as exciting to you as they are to me. I presume that you understand how complicated this particular step is since you're dedicating an entire webinar to step 3. I'm assuming you're experiencing some of the challenges with this step in such the same way that we've been experiencing. So let's start off with just talking about step 3 and the concept of step 3 being what we call a continuity of care step. We see step 3 as one of the key steps in continuity of care, and we see the goal of continuity of care is a mechanism for assuring accuracy and consistency of information provided to pregnant and postpartum women. So I just, whoops, no, I'm not. Whoops, okay. We look at 2 of the 10 steps to successful breastfeeding as being continuity of care steps, and those are steps 3 and step 10, because both of those steps entail partnerships with outside providers. The hospital can only do so much of the 10 steps to successful breastfeeding on its own, but when it comes to step 3, the hospital itself is impacted by external healthcare providers as well as external community programs such as WIC that are working with some of the women that are delivering in their facility. And the same thing that happens with step 10. They're both steps entail work with outside providers, and thus, in my mind, the opportunity for some great collaboration. Whoops, I jumped ahead a little too quickly on that. We have been encouraging hospitals that are working towards baby-friendly designation to form continuity of care committees. And what I want to say is that we encourage it, we do not require it. But what we see the purpose of continuity of care committees being is a mechanism for assuring that an adequate number and type of breastfeeding education and support services are available to pregnant and postpartum women. We also see a key goal of these committees is to assure that that accurate and consistent information is provided to pregnant and postpartum women. I mean, one of the reasons we hear women discontinue breastfeeding prematurely is they're confused by an array of inconsistent advice provided to them. And so if we're all on board with the goal of trying to increase the initiation and duration of breastfeeding in this country, one of the most successful ways we can do that is assure that we're all providing good, consistent information and advice to women who are trying to nurse their babies. So we think a very important role of continuity of care committees is to work with community providers and the community at large to prepare pregnant women for maternity care practices that they will receive at a baby-friendly designated hospital. We know it's extremely challenging for a hospital if women show up ready to give birth and they're not prepared for practices such as skin-to-skin and rooming in. They may not have a positive response to them initially if they're just learning about these practices upon the birth. So if they're better prepared prenatally for experiencing these practices, that they're more likely to be receptive and embrace the practices. And again, as I said, these committees, continuity of care committees, are not a requirement, but we see an opportunity of continuity of care committees to work with the community and the hospital to support the development of policies that support the practices. And again, these are not required policies, but many hospitals have found that reducing visiting hours for new moms and their new families helps support some of the practices. Moms aren't distracted by visitors and spend more time skin to skin and rooming in with their babies and get a lot more bonding time with their baby while at their hospital. We see that continuity of care committees are helpful in addressing sometimes cultural issues. So there are some cultures that have been resistant to one or more of the 10 steps to successful breastfeeding, and having a committee of hospital personnel as well as other community care providers working with particular communities explaining the importance of particular practices may help gain the support of that culture, and then women from those cultures be more inclined to embrace those practices. Another opportunity for a continuity of care committee is to provide joint training between hospital and community personnel, which would assure some consistency of information being provided to pregnant women and mothers. They also can provide needed support to the hospital when the hospital is experiencing bumps in the change process. And for any of you who are going through the baby-friendly process and are feeling some bumps along the way and maybe some resistance to change, just know that's a normal part of any kind of a change process. And while it's frustrating, a lot of hospitals in this country have worked through it, and sometimes they work through it internally, sometimes they work through it with the help of some external support systems. So the Continuity of Care Committee might be a mechanism that would provide you some external support, and they may not. Again, each of you will use your committees however you feel is best suited to your needs. who should be included in a continuity of care committee if you decide to create one. It's always a little bit dangerous to create a list, because anytime you list a particular resource, you leave a resource off inadvertently. So please forgive me if this list isn't as comprehensive as the resources within your own community, but around the country there are various, the resources will vary from place to place. So you're going to want to bring in community resources that make the most sense to you in your setting. Here are some examples of some types of groups that may be included, such as community health care providers and their staff, community programs such as La Leche League and any other breastfeeding peer support program, WIC, parenting program, breastfeeding coalitions. Some communities have these great nurse-family partnership programs. Some have other kinds of home health programs. Private lactation consultants are wonderful resources in continuity of care committees. Hunger advocates. And we just encourage you to think creatively about who else might, at the community level, might be interested in the work of continuity of care and want to partner with the hospital in its baby-friendly journey, and think about who will help you along the way. So there's no right or wrong answers in terms of who should be included. I think that's up to you all as to who would make the most sense given your resources in your community. One of the questions that we were asked to address prior to the webinar, several of you had emailed questions into our organizers, and you've looked at some of the tools provided to you by Baby Friendly USA and noticed that in your development phase toolkit there is a continuity of care survey. And so one of the questions that we were asked is, how does the continuity of care survey factor into step 6? So this survey was designed to assist facilities in gathering information about education provided to pregnant women and postpartum women in the community. We envisioned each facility would use it to survey the appropriate community representatives that were working with women who deliver in their facility and compile data about the education that's being provided as well as other services. We thought that that data gathered from the surveys could be shared at a continuity of care meeting that could be used to talk about what services exist, what information is being provided, and what gaps exist, and then how might those gaps be filled. So it's an idea. You'll see at the point at the bottom of the slide, this is not a mandatory activity, but we thought that this would be something that could be helpful in helping facilities carry out the requirements of step 3. Another question that was sent in prior to this webinar is, should family practice providers who deliver babies be surveyed? And once again, who you decide to survey is the choice of the facility. But we do know that prenatal providers are key players in preparing pregnant women to experience the 10-step practices at the hospital, as well as preparing women to breastfeed. So since the goal of the continuity of care survey is to promote consistent messaging among all providers, I think it is appropriate to select the providers that deliver at your facility. So if that includes family practice providers, that probably does make sense to include them in the survey. But if for some reason that doesn't make sense to you, it's not a mandatory activity, and therefore you don't have to survey them. So moving in more specifically to the topic at hand, I want to dig in and talk a little bit more about the requirements of Step 3. I want to start off by sounding a bit like a broken record and reminding you that the most important tool that you have to guide your work is our baby-friendly guidelines and evaluation criteria, and those can be downloaded from our website at www.babyfriendlyusa.org. And this is the most important tool that you will use in your baby-friendly journey because it outlines all of the standards that must be achieved for each of the 10 steps to successful breastfeeding and the International Code of Marketing of Breast Milk Substitutes. So it is the tool that whenever you have a question, that should be the first place you should go looking for an answer to what your question might be. And most times the answers are found within the guidelines. But I want to just explain a little bit about the guidelines in case you don't already know what's the difference between a guideline and a criteria for evaluation. The guidelines and evaluation criteria, as I'm sure you've known, are laid out by 10 steps in order of the 10 steps to successful breastfeeding. So under each of the 10 steps, you will see a series of guidelines which represent the standard of care that you're striving to achieve for all patients. Underneath each guideline, there's one or more criteria for evaluation. The criteria for evaluation is the minimum standard that must be met in order to be awarded baby-friendly designated. So we're always encouraging facilities to strive to implement a practice for 100% of your population, but there's a threshold of 80% that's needed for passing grade. So that's the difference between a guideline and evaluation criteria. We do understand that a particular care practice may not be implemented 100% of the time for a whole variety of reasons. Sometimes it's a medical indication, sometimes it's a mother's choice, sometimes there's just something that's gone awry in a particular situation. We understand there's human error, and so that's why we've set the 80% thresholds for achieving the guidelines and evaluation criteria. So moving on to talking specifically about step 3, which is, as I'm sure you all know, inform all pregnant women about the benefits and management of breastfeeding. We see this step as an important step to lay the foundation for breastfeeding and the mother's acceptance of the care practices she's going to receive at the facility. Healthcare is very dynamic, as I'm sure I don't have to tell anyone on the phone, and the dynamic nature of healthcare has now had a significant impact on how we evaluate step 3. With mergers, takeovers, buyouts, creations of systems, how step 3 is practiced out in the world and how prenatal care is delivered out in the world really varies significantly from facility to facility. And so getting into some very specifics on how we're going to assess who often involves some individual conversations with the hospitals to determine how we best assess a facility and which criteria specifically apply for you. But essentially, we've created 2 different sets of criteria for step 3, and that is a set of criteria for facilities who have an affiliated prenatal care or service, and a set of criteria for facilities who do not have an affiliated prenatal care or service. So naturally, that begs the question of what constitutes an affiliated prenatal care or prenatal service. And so we've been examining this question ourselves because, again, as healthcare has changed, it's really pushed us to think this through at a very deep level and offer some guidance to you on how you should proceed with implementing this step. So a primary trigger for us for determining which criteria will apply for a particular facility is whether or not they provide prenatal care. And we're talking about primary prenatal care for patients. So if prenatal care is provided to pregnant women by employees of a facility, and in some cases employee of the system, and here's where we have to have some individualized conversations with you, because sometimes all of you are employees of a system, sometimes you're all employees of a facility, and then we really have to think about, you know, how your system operates to determine how this best applies in your situation. But let's assume the most simple of circumstances and say that if prenatal care is provided to pregnant women by facility employees, then the affiliated prenatal clinic or service criteria apply. And specifically what that means is that during the assessment, we're going to select a random sample of pregnant women to be drawn to have interviews conducted during the assessment. Whether or not the facility employees provide prenatal care or not should not be the only consideration of a facility regarding the efforts they make to provide prenatal education. So if prenatal services are provided on facility-owned property by privately incorporated medical groups or another contractor, it's likely to be perceived by the patient to be offered by the facility. In this case, our expectation is that the facility will make an extra effort with this maybe unaffiliated service to make sure that this medical group provides the education on the necessary topics, because it's very likely that your patients have selected that care provider because they're affiliated with a baby-friendly facility. But if they're not, if the prenatal care is not a part of facility services, then those pregnant women are not randomly selected for interview. We're going to be measuring your level of effort with that group. So prenatal service is considered to be childbirth education classes, breastfeeding education, and antenatal classes. So if the facility is offering those services, we are not planning to interview pregnant women for those who participate in those services, but we do expect that if the facility is offering those services, that breastfeeding education and the required topics are included in some of those classes that are offered and services that are offered to pregnant women. So let's talk specifically about the guideline for Step 3 for facilities with affiliated prenatal clinic and services. So our guidelines state that education about breastfeeding, including individual counseling, should be made available to pregnant women for whom the facility or its associated clinics provide prenatal care. This education should begin in the first trimester when possible. So for this particular guideline, the evaluation for the criteria for evaluation is if the facility has an affiliated prenatal care clinic or services, the nursing director or manager will report that individual counseling or group education on breastfeeding is given to at least 80% of the pregnant women using those services. And then the guidelines go on to cover what topics must be included in that education. So you'll see here on this slide, and it's probably a little harder to read because it's smaller print, that the education must cover the importance of exclusive breastfeeding, non-pharmacologic methods for pain relief during labor, the importance of early skin-to-skin contact and early initiation of breastfeeding, rooming in on a 24-hour basis, the importance of feeding on demand or baby-led feeding, frequent feeding to help assure optimal milk production, effective positioning and attachment, exclusive breastfeeding for the first 6 months, and the importance of breastfeeding to be continued after 6 months even when complementary foods are given. The guideline continues that individualized education on the documented contraindications to breastfeeding and other special medical conditions should be given to pregnant women when indicated, but it should only be given when indicated. It shouldn't be done on a group basis. Here are criteria for evaluation for this guideline, is that we are going to be looking at the written description of the content of prenatal education, and when it's available, and that education will cover the minimum of the importance of breastfeeding, the importance of exclusive breastfeeding for about 6 months, and basic breastfeeding management. So here again you'll see the difference between the guideline and the evaluation criteria. The guideline lays out the more broad topics that should be covered. The criteria for evaluation is a little bit more limited in what you can pass if you've implemented. Another criteria for evaluation under that specific guideline is that of the randomly selected pregnant women in the 3rd trimester who are using the facility prenatal services, at least 80% of those women will confirm that a staff member has talked with them or offered a group talk that includes information on breastfeeding, and then we're going to ask them some questions about what they've learned about breastfeeding, and at least 80% are going to be able to describe to us what was discussed about 2 of the following topics, which would be the importance of skin-to-skin contact, rooming in, and the risks of supplements while breastfeeding in the first 6 months. Moving on to talking a little bit about the criteria for facilities without affiliated prenatal clinics or services. The facility should foster programs that make education about breastfeeding and individual group counseling available to pregnant women for whom the facility provides inpatient services. The education should begin in the 1st trimester whenever possible. And then the criteria for evaluation for this particular guideline is that if the facility does not have an affiliated prenatal clinic or services, the nursing director or manager will report that the facility has provided in-house breastfeeding education through childbirth education or tours or whatever contact the facility has with pregnant women, and or fostered the development of community-based programs that make available individual counseling or group education on breastfeeding and coordinated messages about breastfeeding with those programs. So here's where we see continuity of care committees really coming in with this criteria. Some of that coordination of messaging will happen through the continuity of care committees, as well as some of the fostering of new programs will come about when and if survey results indicate gaps in services and the facility works with a continuity of care committee to create a service or education program where none exists. So continuing on in the unaffiliated prenatal clinic criteria, the guideline goes on to say that when you're fostering programs, you should foster programs that cover the educational topics that I just described to you that were required for the affiliated clinic. We do ask that you work with other programs to make sure that they're covering the same topics that you would be covering if you were providing the education directly to the women yourselves. And once again, encourage them to provide individualized education on the documented contraindications to breastfeeding and other special medical indications, but again, having it done privately rather than in a group setting. As we're looking to evaluate this particular guideline, the criteria for evaluation includes a written description of the in-house and or community-based programs and projects the facility has fostered will be made available and will cover at the minimum, those programs will cover the importance of breastfeeding, the importance of exclusive breastfeeding for about 6 months, and basic breastfeeding management, including skin-to-skin, rooming in, risks of supplements, etc. So that's kind of a general overview of the guidelines and evaluation criteria, and then I wanted to take some time and start to address some of the questions that you all phoned in or wrote in prior to this call, but also want to include my co-panelists in some of this discussion. So I'll lay out a question and I'll turn it over to Lori, and you can help facilitate some discussion among the panelists. But the first question we were asked to all address is the questioner indicates that they do not have an affiliated prenatal clinic or services, and the hospital offers a breastfeeding class 2 to 3 times a month. how does this specific hospital meet step 3 if they don't have access to pregnant women until they come to deliver? So from the Baby Friendly USA perspective, we would assess this facility using the facilities without affiliated prenatal clinic or services. So our assessors would be looking at written information about community programs that were fostered by the facility, and we'd also be looking at the agenda for the hospital breastfeeding class to see that the required topics were covered in the classes that were offered to the pregnant women, and that the hospital did what it could to provide education to pregnant women when they had the opportunity to provide that education. But before we move on to the next question, I'll turn it over to Lori to also invite the other panelists to share their experiences with this particular topic.
So I just was going to see if any, Tamara, thanks for joining us, Karen or Eileen, I believe you're unmuted on our end. If you'd like to share maybe how this applied to you, if at all. Do you have anything to add from your local experience? So how about Karen, do you? Okay, so we don't have Karen. Or wait. There's she's okay, and Eileen, how about you? You can type if you can't speak. Or Tamara? So I think you guys are self-muted because we've unmuted you on this end. And Tamara's with Skyridge, and she missed her introduction, but she actually helped a hospital through much of the journey to become baby-friendly in California.
Can you hear me now? This is Eileen.
Yes.
Yay.
Yes, Eileen, go.
I don't really have a lot to add because we do not have affiliated prenatal clinics, but we certainly did work hard to talk with our physicians who did offer. We have a couple of large practices that do offer their own prenatal classes, particularly breastfeeding, and so we worked with them just to look at their content and ask them if they would include certain items. You know, we really didn't have jurisdiction over their content, but they were lovely to work with, and we just asked them if they would make sure that they included a couple of items that were required but not currently being covered.
So Eileen, do you have any best practices for how you were able to reach out and engage those practices of physicians? Like anything that really worked well for you?
I don't know if it's best practice, but it was our practice that I called their office managers and said, can we come to your staff meeting? And we presented a very brief overview of what Baby Friendly was and asked them and showed them this step and asked them if they would partner with us. We also, as we were training our physicians, we asked for their help in as we were doing physician education. That was a great contact for us to have in getting some support from the office to say, yes, here's what your physicians are going to be learning now also, and it was kind of mutually urging the physicians to get it done.
Excellent. Excellent. Anybody else want to add on a little how to reach out to that group, those groups?
So this is Trish. I'm going to chime in. We hear a lot of concern from facilities who are experiencing some difficulties working with physician groups, and one of the approaches that we've found to be really, really helpful, if any of you are experiencing some resistance or not entirely comfortable with how to approach, and I think what was just described was an awesome way of approaching physician groups. Another way is that, you know, mothers are so well informed these days that, you know, helping to get physician buy-in to breastfeeding education and participating in the Baby Friendly Hospital Initiative is one of the things is kind of taking that customer service standpoint, because the patients are customers of doctors these days, and they all have choices of where they can go for care. You know, as the customers are choosing breastfeeding more and more, the doctors need to be sure that they have the knowledge to provide the care to the customers that the customers are asking for. And so I would think that the doctors would want to have the information about breastfeeding before the moms have it, and that it would be more comfortable to learn from peers and from lactation consultants about the proper care to provide to breastfeeding mothers than moms themselves coming in with journal articles or some other information that the doctor really isn't familiar with and not knowing how to respond. So taking that customer service end may just have a nice, get a positive response from doctors.
So we have a question from somebody asking if you've had success getting OBs and peds to not give out formula supplements. Anybody respond to that?
This is Eileen, and yeah, I had no problem once I told them why it was important. I think they believed that they were doing something really kind for their patients until we helped them to understand that that was not. And I really had very little reluctance. The pediatricians were very much on board. The OBs a little slower to come along. Research made a big difference.
Presenting the evidence.
This is Karen.
Hi, Karen.
Correct.
So we had one of our we had some luck here in our community when we, asked why in a pediatrician's office, why were they giving away formula, and it seemed that there were some of the nurses who that was a common practice, that they just set up their exam rooms and put formula in their exam rooms. And so once we began that dialogue, they changed their practice so that only the pediatrician could be the person who would go back in the back and get the formula and give it to the specific patient, so that it was only given when there was a medical reason rather than everybody getting it, because there is a perception that they want to be giving something to, and of course the formula companies have really built those relationships in the community with these individual practices. So we really had to address that from another perspective.
Yeah, thank you, Karen. And someone asked the question about what we're talking about when we're talking about supplements that are, we're risking giving in the first 6 months, and we're just talking about formula. We're not talking about herbs or anything of that nature. So it's strictly formula. So Trish, why don't we go on to the second question and answer that you have?
Perfect. Oops. So the next question that was submitted is, we have some affiliated and some non-affiliated clinics. Since there is no accountability required of non-affiliated provider offices, to what extent does Baby Friendly hold the hospital accountable for the education they provide to their patients? So, this particular facility would be assessed using the criteria for facilities with affiliated prenatal clinics. So predominantly we'd be looking at the affiliated clinics of the facility and drawing samples and interviewing mothers that have participated in those clinics. We would also just take a look at written information about efforts made to private physicians to participate in Step 2 training, as well as to provide prenatal education in accordance with Step 3, but we wouldn't hold the facility accountable for the education provided externally. We would just look at your level of effort. So once again, that's a continuity of care kind of an issue there. So let me open it up for our co-panelists to also chime in.
Anybody want to say how you managed to finesse working with the two different groups, the affiliated and the unaffiliated? Additional? camera back on yet? No. Okay, then let's move on to the third question.
Okay. So, and I think we've somewhat delved into this question a little bit, but this might be a little bit more fun to talk some more. So how far do we have to go with educating private physicians? Do we have to visit their office and make certain they don't have formula packs and materials? So from, again, the Baby Friendly USA perspective, assessors will be looking at the written information about efforts made to those private offices. We'll, look at how you've invited them to participate in Step 2 training, as well as ask them to cooperate in providing the prenatal education in accordance with Step 3. We are not going to go to private physician offices of those doctors not employed by your facility and look at, are they code violators? I do think it's really important to try to win them over, as has been previously talked about, because these guys or gals are setting the stage for what's going to happen either in the facility or once the mom gets home. And so if they're violating the code, or if they're not totally on board with the Baby Friendly Hospital Initiative, they may not be giving you the support you need to work with women when they're at the hospital, and they're not helping this country meet our breastfeeding duration goals. So I think a lot of the techniques for working with physician groups, I think we've already talked about, providing the evidence, letting them draw their conclusions themselves about the importance of the evidence and the importance of breastfeeding, and how some of the practices, how they can impact the success of breastfeeding, and and encourage them to form relationships with lactation consultants and others who can help women more intimately and at a deeper level than perhaps they can do. But let me pass this over to our co-panelists and let others chime in as well.
Trish, can you also tell us, when you say you're looking for written materials, I know I've had this question, are you looking for like an email correspondence? Are you looking for an agenda for a meeting that was held? Like what qualifies as written materials?
Yep, I mean, we've been pretty flexible. It's a great question. We've been pretty flexible about, what we'll accept, but we want to see some sort of documentation that meetings have been taking place, that work has been going on in between the facility and providers within the community. So agendas of meetings, invitations to meetings, a written continuity of care plan, a written, like a page narrative of, on such and such a day, or continuity care committee was formed on such and such a day and has been meeting monthly ever since, and they've been tackling these issues. Here's who's in attendance. That's adequate documentation from our standpoint. So anything that really demonstrates the level of effort of a facility is acceptable in our mind. We just want to see that there's been some work with the facilities, there's been some between the facility and the care providers, and that there's effort to cooperate and coordinate with one another.
Great. And I have Kathy in the room here. She has something to add to this discussion.
Just speaking for Colorado Springs, the physicians have been very open to this information, and so we put a webinar together. We used our physician champion, one of the La Leche League leaders, myself, and Mary Lou Howard, both lactation consultants at Memorial Central and Memorial North, and we did a 1-hour webinar through our audiovisual people in the hospital. And mainly we used it as just a jumping off point. So our physician champion mentioned in the webinar the well start, some of the free information, Dr. Hale's websites, links to medication information, the groups, the La Leche League groups that meet in our area. So the physician can use this as computer-based training, because we taped it, and then the physician can go to those websites, do any 3 hours that the physician chooses to do. They could do 3 hours on well start. They could use this 1 hour recorded webinar as part of their 3 hours, and of course they can exceed the 3 hours of training as well. And then this training is tied to their privileges at the hospitals, and how we accomplished that was the OBs decided at OB section that they would tie it to their privileges at the hospital, this training, and then because OB section decided to do it, PEDS followed. Because OB section, which OBs in our community are a little bit easier to get things like breastfeeding done through, so we decided to do it on that step-by-step process. And they have until, I think, the middle of next year to get this training done. I know our session right now isn't about physician training, but that's one way to incorporate them into the plan.
Thank you, Kathy. That's some great ideas. How about other panelists?
I think that
Karen.
Eileen. Okay, go ahead, Karen.
Go on. No, you go, Eileen.
I think that this is one of those times when having the right people on your guiding committee, your breastfeeding committee, your baby-friendly committee is really important, because when you get those chiefs to be there helping you to design a policy, it sets the foundation for the expectations around credentialing or around obtaining the training, because that is written into your policy, or it was in ours, and it just helps it just helps set the foundation and roll out. I think that if you have that information, the requirement in your policy, and I think to tie it to credentialing, almost every hospital has physicians sign some sort of a contractual agreement when they come on to staff, and it just gets tied into what they're signing up for in whatever fashion that is for your hospital.
So question for you, Eileen, is that part of your policy something that you could extract and share with me, that I could push it out to all the members who are still working on their policies, and they could maybe try to get that embedded during this process?
The fact that it's in the credentialing process is not in the policy, but what's in the policy is that physicians will obtain 3 hours of education, and you know, when it's just stated, and you know, nursing staff or other staff getting 20 hours, it's there, and we just kept falling back on that.
Can you tell me where it is? Is it in the breastfeeding policies, or is it in some other policy at the, you know?
It's in our breastfeeding policy, and you're asking me to remember where that, somewhere it is. I will find where that's at, and I will send it to you.
Okay, thank you. Sorry to put you on the spot. Karen?
Yeah.
So I definitely agree with everything that's been said, and really the strongest message always is if you could tie that to credentialing, so that physicians are getting the latest information and they're held responsible, you know, for that information through the credentialing process. So kudos to anybody who can get that through their credentialing committee, because I think that probably is one of the most sure fast ways that we can ensure that. But here at PVH and MCR as well, we had a real calling from our pediatricians who said, you know, oftentimes new families come to speak with us and interview us to be their pediatricians. So, you know, what are some of those key points that you want us to cover from the hospital's perspective when we have these one-on-one interviews? And so we were able to create this document about rooming in and skin-to-skin and no, you know, formula or water, exclusive breastfeeding, so that we could give them a jumping off point of those critical concepts that we would like them to discuss during those interviews. So that was very helpful. And once again, one of those customer things, that they were motivated to speak to the customer about our practices, that to be the best practices.
Thanks. That's very helpful.
Hello?
Yes, that's Tamara? Yes,
Yeah.
you're on.
Oh my goodness, finally. I'm so sorry about that. One of the things that we have not addressed either is the HCAP scores and how important this is to have the continuity of communication amongst our providers. And I think that's one of the things that we really discuss with our providers as well, is that trying to have that playing field where we're all on the same page. And they really appreciate any effort or anything that we can give to them to help sort of boost those scores.
Yeah, thank you. I'm trying to take notes on what all you're saying too. So we did have a question though about the written description of like a class content that you provide. Trish, are you looking for broad strokes or in-depth details on this curriculum? Of a class content.
So we would just be looking at the broad strokes are fine. So if there was an agenda for the program, whether it's a 2-hour childbirth education tour kind of orientation, and you say like point number 3, breastfeeding education, and sub bullets listing the topics, that's acceptable. So we look just reasonable documentation of what's being provided, and that it's part of an overall plan, and that there's some sort of a plan for making sure it gets covered in the class, but it doesn't have to be a written description of every point made under those broad topics.
Great. Any other comments from the panel, and we'll move to the next question.
So I'm going to just add a couple points that I thought about as each of our co-panelists have been talking. For some of you who are struggling with getting physician buy-in, each of our panelists have talked about success they've had at their facilities. And so, many times doctors learn well from other doctors. And, one of the best forms of flattery, is asking people for their opinions and whatever. And so, this might be an opportunity for, some collaboration from facility to facility, and maybe some of the doctors, from Eileen's or Karen's, Kathy's, or Tamara's facilities may be able to help some of your doctors tackle some of these challenges, and they might learn well from one another. And so, even as a state, you might want to talk about a physician's webinar where physicians can work with physicians on some of these issues. So that might be another way of getting buy-in. I think several of the panelists talked about step 2 work. I think step 2 is a very nice entree into step 3, because once you have provided the education and people have learned about the importance of a particular topic, the next logical place to go is how are we going to apply this with our patient population. And so I think, when I talked about continuity of care committees, a really nice function of a continuity of care committee is joint training. And when people are learning together, it's a natural environment to plan together at the same time. Like, oh, we've just learned this important thing about breastfeeding. How are we going to get this to our patient population? Sometimes the training and planning happening in combination with one another can build some really strong bridges. So, just kind of want to throw those out there. Another idea that I believe I'm in a great position to steal thoughts from all around the country and share them with others. So an idea stolen from New York City is that they have implemented a program that they call public health detailing, and it's based on the pharmaceutical model of detailing physician offices with information about their products, but the New York City Department of Health and Mental Hygiene provides physician offices with information about public health messaging. So when they've got their anti-smoking campaigns going on, their anti-drinking and driving campaigns, and they've had a breastfeeding campaign that they send out teams of public health workers to detail physician offices with packets of information and research, and sit down with the physicians themselves and or their staff and go over some of the information in the packages. And so this is all done through the public health department. So the state folks may want to talk to the city folks and get the information that's in the public domain, and then could be disseminated to communities to see how that might work or might not work in your community, but just an idea to pass along as well. Should we move on to the next question?
Yeah, go ahead.
Actually, I have a question on that, or
Sure.
suggestion or a recommendation. I guess being kind of new to the community, one of the things that I have had a challenge with is really knowing who contact points or people would be at local areas, such as a WIC contact and things like that. And I don't know if there would be a statewide resource list that we would be able to create with contact names and numbers that might actually help all of us a little bit in this area.
So I can answer that because I work for WIC too. So you could contact me, certainly. We have a coloradowic.org or .com, one or the other, website, which actually has phone numbers and for all the agencies, clinics, not names though. So if you went directly to me, I can provide that for you for your community.
Thank you.
Back to you, Trish.
Okay, perfect. So another questioner was wondering, will Baby Friendly interview mothers regarding prenatal care in English and Spanish, and what about other ethnic groups such as Somali, Vietnamese, and Chinese? So I'm guessing this is the bad answer, or the good answer, but moms who do speak languages other than English are included in our assessment. We do not have assessors that speak a Somali or Vietnamese. We do have Spanish-speaking assessors, but we ask facilities to provide the same translation services to our assessors as they make available to healthcare providers. And part of our rationale for that is making sure that the questions get asked in the same way of patients that information is delivered. So we don't want our assessors to speak a dialect of a language that isn't commonly used in a particular setting, and so we ask the facility to provide those translations to us. But those moms are included in our assessment. I don't know if any of our co-panelists would like to add on to that. Feels like a direct baby-friendly question, but if any of you have had any experiences with us interviewing moms in a language other than English at your facility, please share.
We did have one Spanish-only speaking family, and we used our translation line during the on-site visit.
Okay. Yeah, and my sense.
Go ahead.
I was going to say my sense was that worked very well. But go ahead, Jennifer.
Yeah, I was just, I'm not sure how you provide services, say if you're Estes Park and you have a Vietnamese family show up and you don't necessarily have an on-site interpreter, but maybe I'm thinking that maybe most hospitals use some kind of online or telephone service for translation, interpretation.
That is our experience. Yeah, that most hospitals, if it's a language that's commonly spoken by a significant percentage of the population, there's often on-site translators. But if it's the occasional language, most facilities have connections with a language line of some sort. I think that's a proprietary name, but there's a lot of telephone interpretation services for healthcare, and so most hospitals have some sort of a contract for those services.
Would you expect the materials then to all be translated into, we typically in our state translate everything into Spanish, but we don't necessarily have multiple languages, and that would be acceptable?
Yeah, we might make a recommendation. We say languages, materials have to be translated into the languages predominantly spoken by the patient population. I think with how transient the population is, any one of us could have a patient that speaks a really unusual language show up at our facility, and we may not have written materials for them, and we certainly understand that's going to happen. So if it's the occasional language, we don't have that expectation, but if it's a fairly regularly spoken language, we do expect the materials to be translated.
Great. Let's see, don't believe we have any questions. So would you like to go to the next
one?
slide?
So Is it true that Baby Friendly will not audit charts for documentation of breastfeeding education? So, when we went through the evaluation criteria, you'll see that the focus of the assessment for step 3 is that we look for an affirmation from nursing leadership that education has been provided or is regularly provided. We look for education topics provided to mothers. We, in cases of the affiliated prenatal clinic, we learn a little bit more about mothers' knowledge through interviewing mothers, and then we look at the development of community programs. So for step 3, we're not doing a chart audit, nor is there typically a reason for us to have to go to the chart to look for the documentation. We look for step 3 compliance with documentation of education when we're evaluating the infant feeding policy. There's a piece in there where we ask on our policy checkoff tool, how will this education be provided and how will it be documented? So in the case of step 3, we pretty much assume that the facility is following their policy there. So as you're noticing, I'm couching my answers with really being specific to step 3. But I will say, just in general, the baby-friendly assessment is not done predominantly on chart audits at all. It's, if you look at our evaluation criteria, it's predominantly done on patient, staff, administrative interviews, observations, review of written materials. Charts are reviewed when we need to reconcile differences between what we understand a practice to be and something that's reported to us. So, and now I'm going to wander off the topic of step 3 and just kind of answer that general question around chart audit. If during an interview with a postpartum woman, a mom reports to us they are not experiencing a particular practice, we would go to the chart to make sure there was a medical indication for that not happening. In the case of step 3, there probably wouldn't be a reason for us to have to go to the chart. So that's kind of where we are on that subject. So I don't know if others experience anything different. I think this is sort of a baby-friendly question, but other panelists certainly feel free to chime in if we did something different than one I described at your facility.
No, when I read that question, I was actually not thinking about it in relationship to step 3, but during the assessment phase. And I will say that our auditors did, we had some inconsistencies in what mom said and what nursing staff were saying at the same time, and we did have to go to the charts to show that there was documentation of education to mom and things of that nature in real time during the assessment.
Yeah. And that's typically what we do. There sometimes are inconsistencies, but those like moms might not always know why they wouldn't have experienced a particular practice. I mean, they were in the middle of a medical crisis, and you just took care of business. We're interviewing the mom. The mom says, "No, they never did something for me. I never got immediate skin-to-skin." Meanwhile, you've been performing, miracles on that mom, and we just would verify in the record that something happened that would prevent immediate skin-to-skin. So that's the kind of thing we look at charts for. So that's the questions that I knew were asked of us all, but we have more time, so I certainly would love hanging out and talking with you all. It's much better than what else is on my plate for later today, so there are more questions.
Does anybody have more questions? Did you send in a question that we didn't answer?
Come up on the...
Seems like your slides picked up all the topics, and then how about, let me start with Karen. Do you have any last words of wisdom about accomplishing step 3 struggles and how you overcame them?
Well, this is Karen Moore, and I am in the redesignation auditing phase for Baby Friendly. All my data is due December 16th. So initially when we began our path to Baby Friendly, we poured a lot of energy into talking to all providers, making sure everything was in line. And so based on my re-audit, I'm sure I'm going to have an action plan, because it was really a disconnect between what I was asking these women who were pregnant, and then what I was finding for my postpartum care. My postpartum care is all right on the money. All those practices are happening inpatient, but did they all know it was going to happen when they were pregnant? And so there's a real disconnect. So I know that it's an effort that's going to require ongoing special consideration so that we can always be connecting with our providers in that mechanism so that the patients are hearing what they need to. I'm in that group that's affiliated, but most of my patients come from private practice, not from my affiliated clinic. There's only a small portion of the patients who deliver. So some energy will happen there. So that would be my only thing, is never ignore anything that you're working on. Keep going back to it. And that's one of the very nice things about Baby Friendly now, is that we have a whole QI process that Baby Friendly is helping us with, so that we're auditing our practice every single year after we're designated. So I sure appreciate that effort they have made into that program.
That's wonderful, and I don't know if this is something that the listeners would want to know, but as I think about you juggling, all of you who are well into it, juggling all these different pieces, how do you organize the work plans? I mean, do you I mean, I don't know if you can just learn from one another on how to stay on top of all these different steps going, at the same time, if you had any one nugget of information which has helped you to keep on top of it that you'd be willing to share to our hospitals just into the venture, I think it might be helpful. Do you have any, Kathy?
I could say, this is Kathy, that if I think getting the community involved is important, not just for step 3 and step 10, but for most, if not all of the steps. Once the word starts getting out there of what you're working on and that people from the community are involved, it starts to snowball because the mothers pass the information on amongst themselves. Mm-hmm. And they come with a certain expectation, not everyone, but many of the mothers, because they talk with each other. And that goes a long way. So it's sort of like a ripple effect, which is effective just throughout the community.
Nice. Anyone else?
I think it can be a little bit overwhelming. There's a lot of different steps and tasks that need to be accomplished from the beginning to the end. So I think just really setting a very large time frame that you're going to be able to accomplish all of those steps, and then allowing yourself a lot of flexibility in between those, I think is really helpful. I keep a huge binder of all of the materials and work that's been done. That sort of helps keep me straight. I don't know if that's answered kind of the direction you were going with that question as well.
No, I think that's helpful. Like maybe for some people, keeping it all in one huge binder is a constant reminder of that other tab.
Yeah. And for us, we really a very, very big time frame for getting this project done, knowing that this is a huge process improvement project, so it's not something to do in a really short amount of time, but really looking at annual goals of what we're going to accomplish every year to work towards that big end goal. Kind of how we're looking at it.
That's great. Eileen, did you have any lasting words of wisdom on this topic?
I think it is mostly about policy, getting the right people at the table, and I think just from a more logistics framework, it is helpful for me. I did have a file for each step 1, 2, 3, 4, because as you go through this process, you find so much literature and so many, you get tidbits and issues that it becomes very overwhelming. And I think that it's easier to bite off steps at a time instead of looking at the big picture. it's just very overwhelming. That was something that helped me.
Uh-huh.
And this is Trish. I'm going to chime in too and say that most of our panelists went through the baby-friendly process before we introduced the 4D pathway, and it is your experiences that helped inform the 4D pathway and hopefully helped us develop materials that the rest of you who are on the phone are using now and having an easier experience. I mean, we really owe a huge debt of gratitude to the pioneering organizations that took this challenge on early on, before we had a lot of tools and materials and experience with the whole process. With that said, in your development phase toolkit, there are some model action plans, and there are action steps for each of the steps to implement. So the model action plans are organized by step, and under each step there's a series of actions that could be taken to implement that step, and we designed it sort of as a checkoff tool, as something that you could use to help you keep track of the work and make sure certain things are accomplished, because there is a tremendous amount of stuff to keep track of. So if you haven't been using those plans, I hope you'll take some time to log into our website and download those, because they were designed to help you with tracking. And then Karen mentioned that she's in the annual QI process and is busy auditing her practices, and I do want to let you all know that, and I think, Tamara, I think I heard you're in the dissemination phase and maybe using these tools, but the audit tools that are used in the annual QI process are the audit tools that we supply to hospitals in the dissemination phase. And our hope is, as Karen has pointed out, that even after you're designated, there's always work to keep up with. It's easy for practices to slide, and so we're now asking hospitals to audit their practices to make sure they remain in place, and to put quick actions in place if you see any slippage. It's much easier to stop the slippage from happening than have to fix it later on after you've slid too far. So hopefully those tools will help you achieve designation and then ultimately help you maintain your designation. So things for you to keep track of.
Thank you, Trish. Well, I think that concludes the presentation portion of the step 3. So I want to thank Trish McEnroe and Kathy Janoka and Eileen Meisner and Tamara Martin and Karen Moore for bringing your local Colorado experience to the webinar. I wanted to mention that the next steps for us will be, please complete the webinar evaluation. The information we get from that helps us improve for future webinars. And I hope you're not yawning like the baby here. But watch for your email for that Colorado Baby Friendly Hospital collaborative charter for you to share with whoever needs to sign off on that, whether it's at the mother-baby unit or if it needs to go up higher in your institution. It might, because it talks about what data we're hoping to get from you in aggregate and combined with other data. We would never call out your hospital alone in this collaborative, so we want to make sure that that's spelled out and clear in the charter. And then watch for the email about the one-time funds. So you might apply this year. We only have a limited amount of money for about 6 to 8 hospitals to receive it this year. So if you aren't in the highest priority to get it this year, we will have the opportunity next year and the following year. And then finally, watch for information about our next webinar, which I just picked out to be March 11th. So it's still kind of tentative because I haven't worked with the committee yet, but you might want to get that on your calendar for 12 to 2 on March 11th. So I'd like to thank you all for participating today, and thank you to our panel speakers, our featured speaker Trish, and all of those of you who joined us today. So have a great day.
Thank you too.
Thank you. Thank you.